Hello, this is Donald Trump.
Yeah.
Hi, so this is Charlie Krasner. We got Mike Stander here, coming out of retirement to join us today. First of all, you guys have any cases you want to talk about or issues you want to get going?
And who do we have joining us by phone? 330-224-1985.
Hi, this is Vicky Kohler with Health Insight.
Okay, hi, thanks for joining us.
Can you guys all hear me in there? Everybody, wiggle your right ear.
There's another one by phone.
And then who else just joined us by phone? 702-604-9323. Can you hear us? No, they left it.
Okay, so, you know, I've been ragging for the last year or so about urinary tract infections and how, you know, you treat the patient and you don't treat the test, okay? The test, the culture results. If the patient has symptoms, we go ahead and treat him, and you ignore if they have discolored urine or smell urine, all that kind of stuff. So, if urinary tract infection, again, you treat the patient, not the test. And so, that whole principle of treating the patient and not the test is really applicable to C. diff. And because there's these new tests, the PCR testing come out for C. diff, and a lot of there's a lot of confusion about C. diff. How do you diagnose this, and when do you treat these patients? And so I'm going to try to help straighten that out. C. diff is, you know, we had this 5 years ago. We'd be talking about MRSA taking over the world, and now we're just happy to see an MRSA patient because C. diff is really, it's really just a calamity in the hospital. You know, we just have, every ward has C. diff, and it's really become the major nosocomial problem that we're dealing with. I think, I'm sure you guys would agree, it's just, in the hospital, it's a very big problem. And so, but it's also being over-treated, okay? So, the whole talk today is really about treating the patient and not the test. So, do you have a little control to this?
Okay.
So, let's review some stuff and then see if we can get this, which way do we go here? Okay, this is just the background. You know, they estimate, the CDC estimates that C. diff infection costs us about $6 billion a year. There's about 500,000 infections, 29,000 deaths. And then as a few years ago, it passed the number of deaths of MRSA in the hospital. So it's a big problem. And probably, as you know, we have an antibiotic stewardship program. Probably the number one cause is overuse of antibiotics. The number two cause, which I'm going to review for you, is that there's a new virulent strain that's come out that's really a nastier C. diff. It's like a super C. diff. Causes higher mortality, increased relapse. But the third reason that we're seeing so much C. diff is probably over-diagnosis, okay? And that's what I really want to emphasize today. How do you make that diagnosis of C. diff, and when do you treat it, okay? It's not a test result, it's a clinical call, okay? That's what's so important, okay? So, just review, C. diff, it's called the two-hit disease. First, you got to be put in the hospital. You know, if you had x-ray glasses, you could see C. diff spores everywhere. So you get them into the hospital, you get colonized with C. diff. And then, so the first thing is you get colonized. The second, you get exposed to an antibiotic. The antibiotic wipes out your gut flora, and the C. diff does its thing, okay? But not all the time that you get C. diff and take antibiotics. Much of the time, you just have colonization. The C. diff is sitting there not doing anything. We call that colonization. It's not causing any problems. On the other hand, you can get exposed to C. diff, take antibiotics, and then you can get the horrendous C. diff diarrhea, colitis, megacolon, toxic megacolon, and death. So when you get C. diff, and you get exposed to antibiotics, it doesn't mean that you're going to get a severe disease. You may just become colonized with it. And that's what the tests are very helpful in differentiating between when do you treat somebody who has C. diff colitis, and when do you just say, he's colonized, but leave him alone, don't treat him. And so C. diff infection is not a lab test, it's a clinical diagnosis. Okay, so C. diff infection, when somebody's symptomatic, is basically defined as watery diarrhea associated with at least 3 loose bowel movements, watery diarrhea in 24 hours, oftentimes associated with abdominal pain, cramping, fever, nausea, lack of appetite, and leukocytosis. So the diagnosis of C. diff infection is a clinical diagnosis, and then it's complemented by lab tests. It's not a lab test diagnosis, it's a clinical diagnosis, okay? Somebody's, as they're gonna go in, if somebody has a positive lab test for C. diff but has none of these symptoms, they don't have C. diff infection, okay? They're just colonized and they don't need treatment. And so that's what we're gonna talk a lot about today. So this colorful picture, up on the upper left, you see the intestines, the stomach. So somebody gets C. diff on their hands, gets exposed to it, and they have 2 forms. One is the spores, which is the blue one, or the vegetative cells, okay, up here. And they pass through the intestines. If you're not on an acid block, not even, there's no inhibition of growth. So it goes into the small bowels, but it's not causing any trouble. And then on the next thing, on the right side, it goes into the colon. Again, it's not causing any trouble. It's in the colon. It just colonizing the colon, the spores and the vegetative spore and the cells, but it's not causing any trouble. It's just minding its own business. But then on the bottom, you get exposed to antibiotics. There's a vacuum. You don't have these healthy bacteria inhibiting the growth of the C. diff. So also the healthy bacteria are gone. The C. diff are not being inhibited by other healthy bacteria, the microbiome, and they start producing toxins. These toxins are called A and B toxins. And so if you have a healthy bacteria in the intestines, most of the time the C. diff is just going to sit there colonizing it, not causing any problems, okay? But it has that potential to cause these toxin reductions. So you wipe out the gut flora, there's no inhibition, the C. diff starts producing the toxins A and B. They cause inflammation of the lining of the intestines. The whole lining of the intestines gets inflamed and actually comes up off, and you see this, what's called pseudomembranes. Okay, see this next slide. These pseudomembranes are the result of the toxins A and B attacking the lining of the intestines. The whole mucosal lining gets lifted off, and you see when you do a colonoscopy, you see these what we call pseudomembranes. And so this is called pseudomembranous colitis, which is the clinical manifestation of C. difficile colitis with the watery diarrhea, the mucus, the green stuff, the smell, the white count. Okay, so this is clinical disease. It's not because the patient has C. diff in their intestines, it's because these C. diff are now producing toxins. So the cause of this infection is the toxin, the A and B toxin. Most of the time when you have C. diff in your colon, it's being inhibited by healthy bacteria and it's not causing any infection. Okay, so it's just colonization. So how do we this whole talk is going to talk how do you differentiate between colonization that you don't need to treat and actual toxic disease. So this is the manifestation of C. diff infection caused by these toxins. So why are we having more C. diff infection? One of the major reasons is that about 15 years ago, C. diff mutated itself. Instead of being inhibited by a lot of the antibiotics we use, the quinolones, clindamycin and stuff, it mutated itself so it was no longer inhibited by these antibiotics we're using. So we're using a lot of quinolones, we're using a lot of drugs that would wipe out the healthy flora, but this C. difficile was not being killed by it, okay? So one, it was becoming resistant to antibiotics we're using, so it wasn't getting wiped out. And two, it had mutations. Instead of producing just like normal levels of toxin A and B, these mutations totally blocked the ability to inhibit the growth of these toxins. So now we have these C. diff producing 10, 20 times more toxin than we traditionally saw. So we had a C. diff that was resistant to antibiotics, and two, was producing such amazing amounts of toxin that was sort of overwhelming the ability of the antibiotics like vancomycin and flagyl to inhibit their growth, and also there was so much toxin that was causing such severe colitis and increased incidence of death. Okay, and this C. diff, does anybody know what the name of the C. diff is, the fancy term for this new virulent strain? NAP1 strain is...
NAP1.
Yeah, exactly. So NAP1 is a marker of this C. diff that's sort of taken over the world. that produces high levels of virulence and is not inhibited by the traditional antibiotics. And so, as of a few years ago, we had no cases in Nevada, and now approximately half of all cases in Nevada when people are hospitalized are the NAT1 positive. So this is like a nasty superbug. It's sort of like MRSA, how it sort of took over the world. So half of all cases in Nevada are NAT1 positive, which means, one, that they're producing high levels of toxins, two, that they're very likely to cause severe complications, much greater incidence of death and other problems. And two, because there's so much toxin produced, and you get greater complications, and it's also much more likely to relapse. Okay, so it's resistant to the antibiotics, high toxin levels, fulminant disease, and death. And if your lab does if your micro lab does what's called a PCR test, the PCR test will also test at the same time for the NAT1 strain. So they should be able to tell you, if you're doing PCR testing, whether or not you have a NAT1 strain. It's sort of like a red flag that this patient is more likely to have very severe disease, much more likely to relapse on this disease. So this NAT1 strain is the marker for C. diff. That's very nasty. Again, it's about half the cases. Came out of nowhere the last few years. So I want to present the case I have in the hospital right now. This is a NAT1 C. diff case. All right. So in spring of 2016, this 84-year-old male, he was given ciprofloxacin for bacteriuria. He developed C. diff colitis. So the PCR test tells us that he has C. diff. The NAT1 strain tells us that this C. diff is a high toxin producing. Again, he could be colonized with this, but he was actually symptomatic because he had diarrhea. So we'd say this is a clinical case of C. diff. He was put on flagyl. Subsequently, over the next few months, he had 4 C. diff infection relapses, again treated with oral flagyl and oral vancomycin. And so after the 5th relapse, in October, he received a stool transplant where they stick a tube down him and give him a stool infusion, and he did very well. About 2 weeks ago, he had a fall at home. He was admitted to the hospital. He had a hematoma. They thought it was possibly cellulitis. They gave him ampicillin. A few days into his hospitalization, he developed watery diarrhea, hypotension, lactic acidosis, renal failure. His white count went up to 35,000. His abdomen got distended. The stool again showed C. diff PCR, NAT1 positive. Again, this nasty C. diff. And on the day 3 of the diarrhea, he underwent subtotal colectomy where they took out his colon. He's presently on pressors, dialysis, and a respirator. Okay, this is a nasty C. diff. Okay, this is not a joke. So this guy had C. diff. He has an NAT1 strain, and he was clinically very sick with the diarrhea and all the other symptoms. So we call this a C. diff infection. On the other end of the spectrum, we have C. diff carriers. So these are people who have C. diff. The PCR would be positive because they have the C. diff, but they're not sick at all. And so that would tell me that they're carriers, but the C. diff is being controlled, it's not producing toxins. So just having C. diff in your stool doesn't mean you have C. diff infection, it just means you're a carrier. And those are pictures of the spores you can see in the picture down there. So there's a whole spectrum of disease from severe C. diff colitis, toxic megacolon, to carriers. And so what I want to emphasize now is don't treat C. diff carriers because they're not infected. Okay, again, both these patients had C. diff PCR positive, one who almost dies, and the other patients who are carriers, but only one had the clinical disease. So you don't want to treat somebody who doesn't have the clinical disease, which is the watery diarrhea, multiple bowel movements associated with GI complaints. So the question is, are we over-diagnosing and over-treating C. diff infection? Okay, how is C. diff diagnosed? Traditionally, up to a few years ago, we don't do cultures because they just tell you C. diff's growing. It doesn't really help. It takes a long time. Traditionally, we were doing the ELISA test. The ELISA test was a C. diff quick check. And what it does is, there's the 2 parts of the ELISA test. One would tell you if there's a thing called the glutamine dehydrogenase, which is a enzyme found in C. diff. And so you get a positive GDH, tells you that there's C. diff present. It would then also have a test to look for toxins A and B. So you would get a GDH positive plus or minus a toxin test, okay? So that was how we diagnose C. diff, okay? Sometimes we say, oh, the GDH is positive, but we have no toxins, so we think maybe the test isn't that sensitive. But probably what they were doing was they were finding out C. diff that was not producing a toxin. So now everybody's moved to PCR testing. So the PCR is a molecular test that actually looks for C. diff and to see whether or not it has the gene that can produce these toxins. But just because C. diff has that gene that can produce toxin doesn't mean it's producing disease. Okay, so we're getting all these positive PCR tests. All it tells us is that that patient has C. diff in their stool. It doesn't tell us if they're producing a toxin. And so what's happening, a lot of people are getting treated for C. diff because their PCR is positive, but they don't have clinical disease. They don't meet that criteria. They may have diarrhea because they're on lactulose, because they on other things from their feedings and stuff like that. But C. diff treating C. diff should not be based on your PCR result. Okay, so let's talk about the drawbacks to the PCR test. Okay, a positive PCR test tells us you have C. diff, but does not mean active infection, because the C. diff is not the cause of the problem. The problem is the toxins it produces. So only a test that looks for active toxin A and B production can help you determine if the patient really has active infection. So if a colonized patient will have a PCR positive, but their toxin will be negative, and these are patients that are carriers are 5 to 10 times more likely to be found. Only people are PCR positive, 5 to 10 times more are toxin negative than they are toxin positive in the hospital. And we said diarrhea is very common in the hospital due to laxative, dietary supplements, medication side effects, not just colitis. So don't assume a positive PCR test means active disease. That means treatment. It has the potential negative consequences for your hospital. You're going to treat somebody who doesn't need it. You're going to put them in isolation. Your infection rates are going to go up, okay? Because you really want to be able to tell if somebody is just a carrier or he is actually infected, okay? And so what a lot of places are doing, we talked about negative consequences of overtreating CDI. It affects your infection control rates. You have to isolate somebody, exposing them to unnecessary antibiotics, and the patient is in isolation and gets anxious and depressed, okay? So we've basically moved into the PCR generation now, but we're seeing that we're picking up a lot of patients that have diarrhea, but are not producing the toxin, okay? Are not sick with the disease. So what a lot of places are going, based on a study I'll tell you about, they're doing the PCR as a screening test. That just means you're a carrier, but then let's actually look for the toxin itself. And a lot of people are going back to the test, and it's back to the future. We're using the C. diff quick check. That's a test made by, I think, Cephalid. And what it does, if you see that test on the bottom, it tests for the GDH, so the antigen is positive, and then on the right side of that test, you see a toxin. If that's not there, it tells you that the person's a carrier, but he's not producing toxin. Okay, so this test allows us to say, yes, they're a carrier, but no, they're not producing toxin. And if they're not producing the toxin, they're just carriers. So these are the patients you don't want to treat, okay? So this was a study from JAMA, from the University UC Davis. And you can see there's 3 lines here. They wanted to see how people these are patients who had PCR, so they were carriers. And some of them produced toxins and some did not. They want to know, how did these patients diarrhea? So if you look at the highest one, this one up here, these people had very prolonged diarrhea. And so these were patients, if you go up to the corner, they were toxin positive, PCR positive. So these were patients that were just carriers of C. diff, but they were actually producing the toxin. So the toxin test was positive, the screening test showed that they were carriers, okay? The next group is PCR positive but toxin negative. See the line, the yellow? And they compare those with people who are PCR negative, toxin negative. So there was no difference in people who had diarrhea that were not carriers versus those who had carriers if they weren't producing the toxin. So definitely what you're differentiating from is between people who produce the toxin, very sick, versus people who just have diarrhea for whatever reason, but aren't producing toxins, so there's no difference. Again, so the PCR test picks up C. diff, but the toxin test actually picks up patients who are producing toxin and very likely to have their colitis. Okay. So, are we over-diagnosing C. diff? Up to 50% of tested patients don't have diarrhea or significant diarrhea. I'm going to show you this funny thing that tells you what the diarrhea is supposed to look like, okay? So half these patients who are being tested either don't have diarrhea at all or have just loose stools. They don't have 3 or more stools, watery stools. Up to 40% of patients who have been tested or PCR positive turn out to be on laxatives. So the PCR test is 100% sensitive. It tells you there's C. diff in their stool, but it only has a 45% predictive value that they're actually have disease. So this is the Bristol stool scale, which I just recently learned about. And this is, if you have C. diff, you're supposed to be, if you look on the child's one, you're supposed to have gravy for diarrhea. All right? So this, unless they have gravy for diarrhea, they should not be tested for C. diff. Okay? So these are called stage 7. It goes from porridge, chicken nuggets, sausage, corn on the cob, bunch of grapes, and rabbit droppings. All right, so C. diff, if you have C. diff that's toxin producing, it should look like gravy, or type 7 on the adult scale, okay? It shouldn't look like 3 or 4, all right? Or even 6, all right? Really should have diarrhea. As we said, the clinical diagnosis of C. diff is watery, type 7 diarrhea, multiple movements, associated often with abdominal pain and discomfort. So, antibiotic stewardship role, treat the symptom, not the test result. Just because somebody has a positive PCR, it doesn't mean they have infection, okay? If they have a positive C. diff PCR, which means they're at least colonized, do they have symptoms? Are they having watery diarrhea? Do they have a white count or not a white count? Do they have belly pains? If they don't have any of those clinical signs and symptoms, they're almost certainly just colonized, okay? Don't treat the test result. And what we're doing at Northern Nevada, now at the VA, here where I work, is we're going back. We're now adding back the C. diff toxin test. So we're doing PCR as a screening test, and then the microbiology lab is immediately switching over to the ELISA test to see if the toxin is present. If the C. diff PCR is positive, meaning they're carriers, and then the PCR test, then the ELISA test for toxin is positive, we're saying this patient has C. diff. If they have clinical indications, go ahead and treat them. But if the patient is PCR positive for being a carrier, but the toxin is negative, we're writing a note saying that, this patient just may be a carrier. It's important to use your clinical judgment to decide whether or not this patient needs treatment, okay? So the other thing is, you guys, if you work in the hospital, you know how the nursing home torches you, okay? They say, we won't take our patient back till we have a test of cure. They want a test of cure PCR test. And you should just refuse, because up to 60% of patients will remain positive after successful C. diff treatment, which means that they're no longer producing Bristol type 7. They're now just carrier state. They are not infected disease. So there's zero role for retesting C. diff. Don't do it. And the micro lab should refuse to test any stool except Bristol 7, the watery diarrhea.
If you get one where, because I've had this a number of times, where we're trying to get a patient out that had C. diff, trying to send them to a nursing home, and they're telling the nurse, no, we can't take them until they have tested cure. I would end up calling them, and usually I could convince them, but the other option is you can tell Washoe County Health to call them, and they'll call the nursing home and explain they cannot do a test of cure anymore.
Yes, but you just pick it. The PCR test is it's a carrier. It doesn't mean anything. What you want to know is how they're clinically doing. All right, these are some things just to review. Increased virulence in the NAP1 strain, which is that nasty strain, is a result of which of the following? Lower rates of germination. Yes or no? No. Higher resistance to antifungal agents. No, which are bacteria. A gene mutation leading to reduced toxin production. Right. Right, so it's
Oh.
ability to produce large amounts of toxin A and B that overwhelm treatment attempts. Yes, a really nasty bacteria. So this is a case that was just written up in JAMA. It was really interesting. A 28-year-old male presented with abdominal pain and diarrhea. They said it was greater than 10 Bristol type 7. So type 7 stools are that watery stuff. It was after a course of augmentin for pneumonia. So he was diagnosed with C. diff infection by the PCR test. So the PCR test, just to review, looks for the presence of the gene that makes the toxin. It doesn't tell you whether or not it's producing. You have a diagnosis right there, but if you wanted to, you could also do a ELISA test to look for the toxin itself. The PCR test tells you that it's a C. diff that has the gene capable of doing it. But you have clinically, you have a diagnosis go. 10 watery stools, he took augmentin. So he was treated with 10-day course of Flagyl with resolution of the symptoms. He returns to baseline 2 to 3 Bristol type 4 stools. So if you go back, type 4 are sausage, okay? Infectious disease is fun. Okay, so he returns to baseline 2 to 3 Bristol type 4 stools per day. Starting 6 weeks later, again has abdominal discomfort for the next 3 weeks, relieved by bowel movements with increased stool frequency. So he has 4 to 5 type 4 stools per day. So he has this increasing number of bowel movements, but it's type 4 stools. Physical exam shows a soft abdomen, white count is normal. A repeat stool test for C. diff toxin PCR, again showing that he's colonized, at least colonized with C. diff. What would you do next to this patient? This is a very common presentation. 1, would you diagnose recurrent C. diff infection and prescribe another course of metronidazole? Why not? Anybody?
Well, one, he doesn't need the type of stool.
It's not infected.
And also PCR, I mean, that's just showing that he's colonized, likely not infected.
Right, so he doesn't fit the criteria. He has 4 to 5 bowel movements, but it's not the watery diet. It just has loose stools, okay? So, and he has a normal white count, his belly is soft. He doesn't have the Bristol's type 7 stool. So he's, again, the PCR is picking up a guy who's colonized with C. diff, but not causing infection. Would you diagnose severe C. diff infection and prescribe oral vancomycin?
No.
Again, no. Oral vancomycin would be used if somebody's very sick and their white counts are over 15,000, etc. How about this? Would you diagnose refractory C. diff infection and consider a fecal stool transplant?
You shouldn't, but they do.
Okay. Don't be judgmental.
Sorry.
Diagnose post-infectious altered bowel habits with C. diff colonization and recommend a high-fiber diet. So that's the answer. It turns out at least 25% of people who are treated for C. diff and it resolves will, at some point next month or two, have loose stools, etc. And it's not, they'll be colonized, but it's not the cause of the infection. They just have, their gut's been wiped out and their bowel flora, it takes a long time to get back to healthy microbiome. Okay, so that's, again, I see people overtreated all the time with Flagyl over and over again, and then they'll do a PCR test that's positive, and they'll keep on giving them Flagyl, and after about 4 times, they'll come see us. But it's really this, it's sort of like an irritable bowel syndrome, because the gut flora is upset, all right? So that is the right answer. I didn't have something I learned. Okay, so the bottom line, C. diff testing should be restricted to patients suspected of having C. diff infection who have multiple watery stools, okay? Don't test people just because they have loose stools, okay? They need to have watery stools, okay? Asymptomatic C. diff colonization is a common reason for a false positive stool PCR test. Again, the PCR is very sensitive at picking up the presence of C. diff in the stool, but doesn't tell you anything about whether or not it's actually causing problems or just sitting there and minding its own business. So how would you go about, if you have a patient with diarrhea, how would you go about determining whether or not it's clinically suggestive? What test would you get next if it's available to you?
The ELISA.
Yes, if you get the ELISA test back in your lab, that's what we're doing, okay? Stool C. diff testing is not appropriate after treatment of C. diff infection in the absence of symptoms. Don't retest, okay? Because it means nothing. It just means they're carriers. Post-infection functional abdominal symptoms occur up to 20% of CDI patients and should be differentiated from recurrent CDI with a careful history, all right? But you know, you guys work in the hospital, everybody gets stool laxatives no matter what. They're all, you know, they're put on Ensure, which gives them diarrhea. They're given regular antibiotics which upset the gut flora. So it's extremely common to find C. diff PCR positive patients who they don't have the watery diet, they just have soft stools, but have no symptoms and they're just carriers. Do not treat those patients, okay? And you may at least put them in isolation or at least, you know, hand so that they do have loose stools, they don't spread it, but do not give those people the diagnosis of C. diff, okay? All right, to paraphrase Bill Clinton, when it comes to C. diff and UTI, it's the patient stupid, okay? So don't reflexly treat PCR positive, okay? Look at the patient, why are you doing it? Are they symptomatic? If they're symptomatic, you don't even need the ELISA test, but if there's ever a question, get that test. And I said, it's very common we're seeing these patients. And now that we're looking for it, you know, I think we're seeing it very frequently that they're over-diagnosing it. Enough people are dying of C. diff, you don't need to over-treat the patients who don't have it.
Does the VA now do the NAP one? Or does it want?
Yeah, we were very slow with the VA. We just got about a year ago, we got the PCR test setting up. And now that all this information is coming about, that we're over-treating it, we're doing the PCR test, and then we're going to flip over. We got the ELISA test back.
But I mean, are they doing the NAP one?
Yeah,
They are.
we're getting a new machine that's going to us in that one too.
Because one thing with the NAP one, it doesn't respond very well to metronidazole at all, and it's often a slow responder to vancomycin. So if you have that, I wouldn't even mess with Flagyl. I would go right to Vanco and then plus minus something else.
My policy, if anybody's in the hospital sick enough to be treated for C. diff, I don't go with Flagyl in the hospital. I just do oral vancomycin, okay? As I said, this guy we just had last week, he went from 0 to 60 within, you know, the diarrhea onset, and within 48 hours, they were taking him to surgery. So this is the NAP1 strain particularly is rapidly progressive, severe disease. You got to get a quick grip on that because it is very nasty. Okay. Yeah. So if anyone's in the hospital, put them on Vanco orally. Have you guys had any experience with the C. diff in your hospitals being an issue? Or any questions about our talk?
Yes, I have one question.
Sure.
I'm sorry to have missed a JAMA article.
Yes.
Is there any correlation between the dosage of the metronidazole or to see if there's relief in symptoms? And then the other question is, are there antibiotics which are more predisposed towards C. diff?
Yeah, that's the answer is always the quinolones, okay? You really have to be real concerned about the quinolones for causing C. diff. They're probably the biggest risk factor in the hospital. And that's probably one of the reasons that NAP1 took off 15 years ago was the overuse of quinolones. Because the NAP1 strain are resistant to it, and the sickle wipes out your gut flora. Those are very bad. Clindamycin is obviously bad, and some of the penicillin.
Ceftriaxone is bad.
Ceftriaxone is bad, yeah.
Yeah. And then there's some that are not inducers, like doxycycline, the tetracycline,
Bactrim, yeah.
Bactrim's not an inducer, aminoglycoside's not an inducer.
Yeah, because you're like for community acquired pneumonia, many times people go ceftriaxone, azithromycin when on the floor. Rocephin and azithro both increase your risk for C. diff. And so one other option is to, if you're going to use Rocephin, instead of using azithro, use doxycycline, because doxycycline has some activity against C. diff and will reduce the incidence of C. diff by 80% compared to Rocephin and the azithro. So that, we're trying to encourage people to do that regimen. Because doxy gives you atypical coverage and has activity against C. diff. So that's a real good regimen. Yeah, Rocephin is biliary excreted, so it gets excreted right into the intestine, so it's really high concentrations of the gut and wipes out the gut flora. I mean, it's a great drug because it's once a day, inexpensive, and works well, but it does increase your risk of C. diff. And the dosing is standard on the flagell. And the vancomycin 125 sounds like a small dose, but if you remember, it's just inside the intestines. So even though it stays in the intestines, which is a very small area, so 125 gives extremely good levels. You know, vancomycin levels 100 to 200, so it's very high level.
Actually, the MIC of the bug to vanco is about 1 mic per ml, so it's very low. The levels in the gut on 125 QID is between 500 and 1,000 mics per ml.
Yeah. Yeah, so a lot of people say, oh, let me give them 250. Yeah, it doesn't. You don't even need that much. Yes. It's just the disease is so nasty, the toxins it just overwhelms it. It's not that it's resistant to vanco, it's just the toxins are just so amazingly strong.
And the other thing is, when you give like vancomycin or metronidazole, that screws up the patient's flora for a long time. So it puts them at risk again, because once the antibiotic's gone, now their flora is going to take 3 months or more to get their flora back.
That's why you get that irritable bowel syndrome afterwards.
Yeah.
Right.
Do you have a hard time finding stool donors?
Down the street, doesn't it?
I'm happy to volunteer is what I'm saying. Well, you know, I could participate if you needed some.
You know, the GI doctors do it in town, but there's this nonprofit group out of Boston, and they have this amazing thing where they'll provide it for you. They screen it completely, they ship it to you, and they're very dedicated people, and so it's a pretty interesting thing. They'll just send it to you. So that's pretty neat.
There's a big the screening test for the stool is pretty elaborate. I mean, they have to look at HIV, they have to look at hepatitis, they have to look at C. diff, they have to look at a number of things to make sure the patient has none of that.
Yeah. What's the place in Boston called?
Open biome.
Oh yeah, it's interesting. Just Google it, openbiome.org or something like that.
Probably,
There are a whole bunch of young people that are very motivated, and they set up this whole program, and so they provide it. That's pretty neat.
It's smart stool. It comes from a lot of MIT students.
Yeah, there's a bunch of motivated students, so that's pretty cool.
Yeah, your patients might get smarter at
Yeah, because changing their intestines will probably make them smart.
No. There you go.
So there's some advantages to getting a stool transfer.
So, hey, we're in Ely. I apologize. We do not carry the vancomycin capsules, tablets, whatever. We just are using the IV orally, mixing it that way. Do you have any qualms with that or any problems doing that?
Well, that's what everybody does. Nobody uses the capsules or tablets. You just make it from the IV.
How long is it good? If you mix it, how long is it good for?
I don't know exactly, but you know, it's good for a couple of weeks anyway. So enough to make it for a patient and have them take it for the course.
Thank you.
Sure.
Yeah, we used to. I think they made it stop us. We used to give them we mix up vanco. It was so cheap. We just say, here, take this home with you when you finish it off. But I think there were some regulations you could do that or something.
Yeah.
Every good deed gets punished.
So under the tables.
Yeah, so that's a great way to do it. That vanco capsule is a big ripoff.
Yeah, big ripoff.
Yeah, what a joke. All right. Well, thank you all.
Any other questions?
Thanks.
Thank you.
All right, so this clinic will meet again next month, February 16th, same time, same place. Thanks, everyone.
What dose are you using?